They resisted change, not only to protect their status, but also because they truly believed that the traditional ways of caring for patients and educating residents were the best ways. As I went along, I discovered as well that not all residents accepted Ironman dictates. Those I came to call reformers had greater interest in change than the Ironmen had because their diverse social identities led them to be disadvantaged in the surgical social system. Unfortunately for these would-be reformers, their early attempts to individually modify work practices in everyday encounters failed because the defenders refused to go along. My search to better understand how power figured into institutional change in surgery led me to the work of neo-institutionalists, law and society theorists, social movement theorists, and medical sociologists. This research pointed to the key actors, processes, and resources that push defenders of the status quo inside organizations to change work practices. It helped me make sense of how changes in the hospital's environment helped bring about change in daily work practices by both pressuring internal defenders and assisting internal reformers. But the processes of change I observed at the 3 hospitals did not fit well with the processes described by any of these theories. In attempting to change long-standing practices, reformers at the 3 hospitals did more than question surgical institutions in the abstract. Instead, they struck at the very heart of each defender by challenging the traditional work practices defenders were skilled in and the deeply held beliefs defenders used to justify their position atop the existing social hierarchy. Defenders had a vested interest in maintaining the status quo, and they protected their traditional practices by aggressively retaliating in the face of change efforts. Change or stasis at the 3 hospitals was the result of fierce contestation on the ground between defenders of the traditional practices and insurgent reformers. I found that to explain the different change trajectories and outcomes at the 3 hospitals, I needed to understand the collective combat processes used by defenders of the status quo and reformers in their day-to-day workplace encounters. And I needed to understand the micro-level resources available to defenders and reformers within each hospital. As I tell the tale that follows, I seek to explain what led to the different outcomes at the 3 hospitals, and, in doing so, advance a micro-institutional approach to the study of institutional change. Introduction. On the night of March 4th, 1984, Alva and Sidney Zion, a prominent Manhattan couple, brought their 18-year-old daughter Libby to the emergency room at New York Hospital Cornell Medical Center. She had a high fever and was delirious. She shook and moved her arms and legs erratically. Sidney Zion called his own doctor and asked him to come to the hospital. Instead, he referred Libby's care to the doctors in training on duty that night. Libby's fever went down, her agitation lessened, and she was calm. A medical resident told her parents to go home, that she would be all right. Soon after that, Libby's fever rose again, and she thrashed about her bed and pulled out her IV needle. A nurse called the intern to come right away. The intern, overwhelmed with too many patients, probably exhausted after a straight 36 hours of work, delayed coming. Libby died at 7:30 the next morning. Washington Post, 1995. Libby Zion's death received national attention, in part due to the efforts of her father, Sidney Zion. Sidney Zion was an author, a columnist at the Daily News, a former reporter for the New York Times and the New York Post, and a former federal prosecutor. In response to Libby's death, he and other patient safety and residents' rights reformers began what would become a decades-long fight to regulate resident work hours. The reformers pressed for and won an unusual New York grand jury investigation of the case. The grand jury directly blamed neither the hospital